Much for being here with us today, to our experts and to our journalists. My name is Tia Ford, and I support Mayo Clinic's media relations team. Before we get started, I want to share a few housekeeping items. In the chat, please find links to our participating experts' bios, the folks that are participating today, and then you will also find a link to Mayo Clinic News Network's uh, website where you can find access to downloadable photos and B-roll, if that will help in preparing your story. And I've also included the email address to the Mayo Clinic News Bureau if there are any inquiries or follow-up questions that any of the journalists may have following today's media briefing or for any other topics. At this point, everyone should have been given permission to record the briefing, but if you have not been given permission, please let us know in the chat and we'll make sure you get that permission. And then we are also recording. We have a Mayo Clinic team member who is recording this media briefing. So if for whatever reason you need access to that video, just let us know. We'll make sure you get it. We're going to be following a similar format as to past media briefings, and we are going to start with some background and thoughts on our topic from our experts, followed by a Q&A. And today's topic is centered around National Minority Health Awareness Month, as well as some discussion in health disparities and prevalent conditions that are having a substantial impact on minority communities. So at this time, I would like to invite each of our experts to provide a brief background on themselves and their areas of focus, beginning with Dr. Dalbany. And before you begin, Dr. Dalbany, I would ask if you could say and spell your name just for our journalists' record so that they can share it accurately. Take it away. You're on, there you go.
Thank you, Tia, for having me in this meeting. I'm Chyke Dalbany, Chyke, D as in David, Oubeni. I'm a professor of family medicine at the Mayo Clinic. I'm also the director of the Mayo Clinic Center for Health Equity and Community Engagement Research. And in addition to that work, I have a strong background in the area of cancer health disparities, as well as disparities in general, and lead a number of programs nationally around the issues of disparities and racism. Just by way of context, I serve as a member of the U.S. Preventive Services Task Force, which is a body that makes evidence-based recommendations on preventive services to improve the health of all Americans. But for this meeting, I am not representing the task force. Thank you, Tia.
Absolutely. And next we'll go to Dr. Halyard. If you could also say and spell your name, and then a brief opening.
Hello, everyone. I'm Michelle Halyard, Michele Halyard. I'm a professor of radiation oncology at Mayo Clinic, and I'm based in Arizona. My specialty is breast cancer. I'm also the Susan Hansen Poole Vice Dean of Mayo Clinic Alex School of Medicine and Dean of the medical school campus here in Arizona. I think this is a really timely topic because of all of the health disparities amongst underrepresented populations that I think all are well acquainted with. This is a perfect opportunity to dialogue because in the COVID era, I think we've exposed even more of the impact of disparities, the disparate effect of health-related issues in communities of color. Part of my research background includes doing research in underserved communities, including looking at research attitudes of patients, particularly African American women. So I'm excited to engage in the dialogue. Thank you.
Absolutely. Thank you so much. And we'll go to Dr. Perez next. And again, please spell and say your name.
Hello, I'm Edith Perez, spelling Perez, and I have a distinct honor and pleasure to be part of the Mayo Clinic faculty and being part of this meeting today. My accent comes from Puerto Rico, just to get this out of the way, but I've been particularly involved not only in academic endeavors, but also to think about improving access to patients to the latest science as well as treatments, particularly in the area of oncology and even in more detail, breast cancer. As part of my career at Mayo, I'm very proud of the way Mayo has evolved in this particular area, including our discussion today. And in terms of my specific activities, I've had the honor to, in the past, prior to 2021, be the chair of the Health Disparities Committee for ASCO. I've been the chair of the Health Disparities Task Force for the American Association for Cancer Research. But now in 2021, in addition to supporting a wide range of Mayo activities, particularly in Jacksonville, through the work with the Donna Foundation and another group called Hope to Jax Saludable, is that I have the honor to be part of a recently initiated a committee that has been started by the National Academies of Science, Engineering, and Medicine, and NASEM, to improve inclusion of women and underserved populations in research. Additionally, I have been the chair of the Health Equity Committee for Stand Up to Cancer since the inception of this committee. We've been able to have a significant impact on the listing of recommendations that we make to investigators, asking for funding from Stand Up to Cancer, as well as conducting the research. So I'll stop here. Again, thanks for the opportunity to be here with you.
Absolutely. And now we'll move to Dr. Hayes. And then once again, if you can say and spell your name.
Thank you. So my name is Sharon Hayes. So it's pronounced normal, but spelled Sharonne, Hayes, Hayes. I am a professor in cardiovascular medicine and cardiologist here in Rochester, Minnesota. I have specialized over my career in heart disease in women, as well as preventive cardiology. Through that time, I have spent a lot of time looking at health disparities, both gender and race ethnicity, in terms of cardiovascular care, as well as in other marginalized communities. And through that work, and I guess one of my other roles is I'm the immediate past Director of Diversity and Inclusion for Mayo Clinic, a position in which I served for a decade. I think as a cardiologist, what I've seen is certainly huge progress in reducing death and disability from cardiovascular disease, but those advantages and progress has not been shared equally. And so really looking at where certain populations have been left behind for a variety of reasons, either because of access, structural racism, disparate risk factors. Another aspect that I have been involved in with Dr. Halyard is looking at how we can improve research participation or help inform and educate regarding attitudes about participation in research for both women and minorities, and have a role in advocating for and training patient advocates. So I'll stop there.
Sounds good. Thank you so much to each of you. And just a reminder to journalists, we're going to move into the Q&A portion of this media briefing. So if you have any questions, please pop them into the chat and we'll certainly share them with the experts. But we can start out with the reason we're here and why we're having this media briefing today. And Dr. Dalbany, I'll direct this question towards you initially, and then we'll have the other experts weigh in. But why is it important that we even observe National Minority Health Awareness Month? You know, what opportunities come from this?
But the opportunities for National Minority Awareness Month are enormous. Unfortunately, as many of us have talked about, there have been issues of systemic social injustices, racism across many generations, decades really, of inequities that have led over time to essentially systemic inequities in health. And one of the sobering things that I personally reflect on is that as a Black man, I have one of the highest risks of dying from just about any preventable condition. And the reasons why that occurs is because of one, there's misinformation, as we learned from COVID. One of the things that I do is that I serve as a PI, one of the PIs of the COVID community engagement work in Arizona State, in addition to my work in Midwest. And we know that there's a lot of misinformation, lack of information in the community. There's lack of access to healthcare. Even when they're in healthcare settings, the quality of care is not as good as they could receive. And there are less opportunities for them to get to care as quickly as they need to. So it's not really surprising that we see across many conditions, from cancer to heart disease to infectious conditions. Of course, COVID is really fresh in our minds, that we see disparities that are very similar. And that is not biological or genetic. I mean, there may be some biological element, but it's because of the structural racism and structural barriers that exist. So it's really important for us to reflect on during this month in terms of being aware of the reasons why these differences exist. And really, more importantly, in my view, is that we actually have opportunities to reverse this. And one of the ways we can do it, and it seems a little distant for some people, is to increase the inclusiveness of research in our communities, inclusiveness in treatment or access to care in our communities. We can do it if we want to do it. And this is a month for us to reflect on that.
Absolutely. Do any of other experts want to weigh in? Dr. Halyard?
I think this is also a month to really talk about what the needs are for the future healthcare workforce. So we know that amongst underrepresented populations, there's an underrepresented amount of people of color, in particular in healthcare. And I think drawing attention to the continued ongoing health inequities and health disparities, and really giving thought to how do we increase the workforce across the spectrum of healthcare providers, including physicians, is another aspect of this month that should be considered. We know that biases do exist when it comes to provision of healthcare in certain settings. We also know that we have a lot of students of color who want to go into healthcare, and we need to be increasingly proactive about helping them achieve their dreams, because ultimately that will help the healthcare delivery in this country.
Dr. Hayes?
I think the other reason this year is particularly important is there's so much noise, right? We've heard so much with COVID, and it allows us to refocus on the future, right? Because there will be another pandemic, which will pull back the curtains again, related to minority populations and disparities. But it also, I think we sometimes get complacent. We think, hey, heart disease is largely preventable. And so we sort of feel like we've got it licked. And I think it does allow us to focus and raise up some of the issues and share how much work is still to be done, and particularly in certain populations.
Yeah, if I follow on the comments, it's, I think, an opportunity to start, really coalescing all of the good that is happening. The discussion has expanded, particularly, but this is something that started a long time ago. Progress has been made, but still there's so much work to be done. So I view this opportunity that we're having. Let's learn of what has worked, and let's leverage from that work to get to the next step. Many people are interested, and they may not know what they can do. Perhaps by learning of what has been successful in some ways, we can speed up the progress that we all know that needs to be made. And I think people will be perhaps sad that we still have this huge health inequity. But on the other hand, I wonder if we can be happy that progress is being made and it's going to speed up, because we all continue to work together on this.
Absolutely. So we've kind of addressed and talked about some of the opportunities for progress and moving forward in terms of health disparities, but what are some of the current challenges in addressing health disparities? How can we leverage or take advantage of this progress and some of the things we've learned in the past year? Dr. Perez?
I'll start. To me, it's a combination of actually three things. First is, do we really understand if there are biological differences or are there social determinants of health which have the main impact on participation of patients in clinical trials or participation in them getting access or to the benefits of the treatments that we develop. So number one, biology versus social determinants of health, so that then we can focus our efforts based on these two general categories. That's one issue. And the other issue, very important, is the healthcare workforce. And Michelle mentioned this. I think this is something that is changing in this country. And as we continue to expand the opportunities that people will have to get into the healthcare field, this will translate into improved health equity in this country. So those are the two issues: biology versus social determinants, and number two, the workforce, all added to the huge impact of education.
Absolutely. Any of our other experts? Dr. Dalbany, you want to?
Dr. Hayes first, and then I can go.
Oh, Dr. Hayes, okay, go ahead.
Thank you. I also think I like to remind us, sometimes we get in our heads on how much science we still need to learn about. There still are so many unknowns. If you say, you can throw up your hands and say, well, we don't know enough about this heart disease or how to prevent it, or we don't know enough about how it affects different populations. But I think reminding ourselves that there is so much that we do know that is proven, that prevents, that treats, that is not provided equally to different populations. So we are not providing, for instance, one of our mainstays, statins, after a heart attack, to the same extent to minoritized populations as we do to white populations. So this is now a generic drug, which is easy to get and easy to prescribe. So we have to look at what then are the barriers. Yes, we look at new science. Yes, we include more people in research, but I think we do need to take a step back and make sure that truly the basics, like controlling blood pressure, like detecting blood pressure even, in population we know are at the highest risk. African Americans are at the highest risk of developing high blood pressure and have the lowest rates of control. When we have literally dozens of generic antihypertensives that we can use that are highly effective. So I think looking and reflecting on our processes of detecting, managing, and the past has not worked for us. So what are new strategies to reach populations? What are new strategies to train our clinicians to do better? And what are ways, again, I'm coming back to the workforce, because if there isn't trust or access to people who look like you, who are handing you a pill, then that perpetuates this problem as well. So increasing the diversity of the workforce will also be a solution for doing the things we know that already work, but we're not doing them.
And I think the thing I would add to that is that, we design our health systems almost in ways to exclude important segments of our population who need it most. And we need to look at how we create structures to meet people where they are. And the technology exists for us to do so. We need to change our mindset from we'll build it and they will come, to a mindset where we provide rich people where they are. And that has to be very important. The other thing that I would add to that is that while we have evidence, oftentimes we develop our solutions and give it to people. That's one of the places where there are challenges and real opportunities for us to change the way in which we approach the way we interact with communities of color, that we have to insert within it a very robust community engagement process that gives control to the community, meet people where they are, community know what they want. So let's work with them to find the solutions, and they are likely to accept it. The trust will exist because they created a solution. They know the answers to these things. We should change those mindsets. I think those are systemic things that get in the way as well.
And I just want to build on that for a minute about this whole concept of community engaged research, because all too often we in our field have trials that are put together that really don't take into account how the community is going to perceive these trials. They don't take into account some of the nuances that can impact participation in clinical trials that that will impact people's adherence to recommendations. And so really it's a mindset shift from sitting behind a desk in an academic institution designing a trial or thinking about how to, whatever you're planning to do, to really partner with the community to understand what their perceptions are, what the barriers would be, and then to really work with the community to design these trials. And I think that is a much more effective way of assuring long-term compliance, in addition to continuing to put in a plug for enhancing the diversity of our healthcare workforce.
Thank you. And just a reminder to journalists, if you have any questions, please pop them in the chat and we will share them with our experts. And we have one from Juan. He has asked, what are some areas that you think progress has been made for minorities? And how do we bridge the gap in healthcare when many cannot afford it? And how about we start with Dr. Hayes?
So I think where some of the biggest progress has been made has been when we have listened to communities and worked with them to develop solutions. One that I've been involved with one of my colleagues, Dr. LaPrincess Brewer, has been in African American faith communities in Minnesota, where we have over years talked to them about what they need and what they care about and what is important to them and how they want to learn more and in what form, and through an iterative process. And what that did, that laying the groundwork, also allowed, when COVID hit, to be able to have a relationship that where we could listen to their needs and find out, what they needed related to COVID. So I think some of it is where we have built relationships and really understand what the problem is, whether it may be cost, and for many it is. But if we assume that the reason people are not taking their medication is because of cost, we can go to a path to failure because it may be a completely different reason. And I think where we have had the most success is not in a particular disease or with a particular population. It is where we have listened and worked with individuals and communities to understand where they are and where they want to go. And if that is not aligned with health, at least to develop a relationship so you can move toward that.
I want to build.
Oh, go ahead. Sorry.
I think so. I can comment on two areas following up on the words by Sharon. Number one is the issue of understanding what the right treatment should be. The right treatments that are currently available should be for the population. And I think Mayo does a particularly great job, where our Mayo Clinic network, the educational activities that Mayo sponsors, the website, where people can get access to recommendations for management for many diseases, because that's part of the role of education. And we at Mayo, I think, do a good job to serve the nation, to serve the world, related to at least making it clear what the recommendation should be based on data for the management of several diseases. And then the other aspect is, I'm going back to research, which is that in the past, many of the research studies were conducted mainly, at least in oncology, mainly with persons of Western European ancestry. And this is actually starting to change because there's a realization that we need to conduct studies that will address the populations expected to benefit from the knowledge that is derived from clinical trials. So I think much more effort is being placed into this so that more changes can be made. And the other issue is that, again, an example of what Mayo is doing, other institutions, other groups are also doing this, is that the clinical trials are sometimes initiated in academic centers. We have the infrastructure, but we're collaborating with community sites, community hospitals, clinics, so that those patients who are not coming really to our main institutions, such as Mayo, can be involved in the progress that we can make with clinical trials.
And I'll just follow up on Dr. Perez's comments. So it goes beyond that relationship goes beyond just clinical trials. I think of Mayo in Arizona's relationship with Phoenix Indian Medical Center, for example. So we send medical oncologists there to see cancer patients, particularly breast cancer patients, to help deliver care there. And some of those patients then wind up coming to us for care as well. And so I think there is a responsibility for those who have more resources to share those resources with the community. I think about an organization that I helped to co-found with one of my colleagues here at Mayo called the Coalition of Blacks Against Breast Cancer. It's now a 501c3, but Mayo had really and continues to provide a lot of support to the organization, where we provide support and education to members of the Black community around breast cancer issues, to educate the importance of screening, diagnosis, treatment, and survivorship. And I will tell you, there's a real impact on having patients come together monthly to discuss their concerns, to discuss their fears about treatment, to not, practice medicine because we're not necessarily their doctors, but to say, this is what you need to ask your doctor. This is what you might consider. And so it's a way that is pretty low cost. There's a certain amount of infrastructure that is provided, but it's a direct intervention with the community, so that we can make an impact, one person at a time.
And I will just add to that, maybe start with news that is not so good, which is that African Americans, for instance, have one of the lowest life expectancies at birth, and that is, I think, is disturbing. But I can tell you about a lot of progress across many conditions, and I'll tell you about cancer, for instance. In lung cancer, the rates of lung cancer and death from lung cancer continue to decline across all racial and ethnic groups, and that is great news. For colorectal cancer, the rates of death continue to decline across all racial and ethnic groups. That's also great news. The other little bit of wrinkle to the progress is that the declines occurred in parallel in both groups. So it's almost as if I've written in the past. It's like our Friedman said this is like the tires of the wheels of a car, right? Both are moving forward, but the back one can't really catch up with the front. But almost as if there's some barriers in a way that prevents African Americans from achieving parity or closing the disparity gap. But the progress is great, and I think it's really important. Let me at least talk about one area that we are working on through the NIH SEAL initiative, which is vaccine acceptance. And the news here is, to me, great news. I mean, there are pockets and areas of work, enormous amount of work that we still need to do. We began with somewhere in the 30s of African Americans and other minority groups wanting to get vaccine. We are now in the 60s, and the number of percentage is actually increasing. To me, that is great news. It offers an opportunity for us to break the cycles of disparities in the communities, but also, to the points made earlier, some of this has come about as a result of the investments and engagement with the community. Town halls mayors led, Michelle Halliard and others that have been on town halls to share information, trusted information. We know, for instance, people trust their doctors, they trust, people who are scientists and respected in their communities, and will leverage these to help provide trusted information, be transparent and honest where we can. So I believe a lot of progress has been made. We've learned a lot. We can build on it and should build on it, but we need to sustain these efforts if we're going to close the gaps that exist. Good news and a lot of work to do.
So an example of where we can really partner with the community and help to improve the healthcare is a vaccine event that's going to be happening at First Institutional Baptist Church, April 16th, 17th, and 18th, and it runs from 8 to 3:45, where it's a vaccine pop-up, and it's really designed to really try to overcome some of that vaccine hesitancy. So it's an example where we're going to an African American faith-based organization. The church is really the center of the Black community, partnering with them to help get the vaccine out. and hopefully to overcome some of that vaccine hesitancy that we see in the community, which, by the way, isn't just within the community. We see this within healthcare workers. So Dr. Dalbany talked about the fact that we are making progress and we're trying to do some things through town halls. We actually held a town hall at Mayo Clinic, having those of us who had been vaccinated talk to some of our Black employee groups to say, we did it. We're still standing. We're still doing fine. Please consider getting vaccinations.
So a couple of you have mentioned this. I've heard it come up a couple of times, with respect to clinical trials and research and the importance of having diversity within those areas. And I'm hoping to expand on that a little bit and talk a little bit more about why it's so important to have multiple ethnicities and backgrounds included in the clinical trials and research that's going on. And then on top of that, just kind of recognizing that there is hesitancy in vaccines, there's hesitancy in healthcare, medical treatment, all of those areas. What do you say to minority friends and family to encourage them or help them understand how important this is? And I guess we could start with Dr. Halyard and then go to the rest of our experts.
So really participation in clinical trials really revolves around issues of equity and disparities. And so in order to make advances in bringing down some of the morbidity and mortality or suffering and death from diseases, we do need everyone to be represented in clinical trials. So we need to understand, do therapies work in different individuals and amongst different groups. And it goes back to what Dr. Perez says, you're looking at biology versus social determinants of health. So we really need to understand, are there differences? Clinical trials often allow patients access to cutting edge therapies that can be life-changing and life-saving in many instances. And so to not have people participate in clinical trials in some ways lessens their ability to potentially get life-saving therapies. But I think it's important ultimately to beat back some of the long-standing distrust in people of color about the whole research process. In some ways, I continue to be amazed, and it's because I've spent the last 40 years in healthcare, about the overwhelming influence that the Tuskegee syphilis study still to this day has on the Black community, including younger adults who never knew about it. They weren't alive when that happened, but it's been passed down from generation to generation. And so, one of the things that we do when we're out talking is to talk about the safeguards that have been put in place to try to prevent those atrocities that occurred with this Tuskegee study from occurring. And to try to help people at least see why we need to participate in clinical trials. It's a difficult thing to overcome years of distrust, but we must still continue. I think this has played out in spades with the COVID vaccine. There's still distrust as to whether the vaccines were tested in enough people of color, even though we know we have numbers of representative numbers in those trials. It continues to be an issue, and I think it continues to impact the uptake of the vaccine within communities of color. So a lot of work to do, but the other thing that I'll say is that Dr. Hayes mentioned that we have done some work on acceptance of research, and it is, underrepresented communities are not a monolith, right? So we sometimes put everybody together and say, oh, Black people don't want to participate in clinical trials. Well, is that really true? Or does it depend on socioeconomic status, education level, et cetera? Some of our research that we've done, which centered around a kind of a higher socioeconomic group of Black women, suggested that their willingness to participate in research was actually quite high, depending on how you frame that research. So I think, this is a continued area for exploration to make sure that we are tailoring our communications appropriately to different populations and not to make generalized statements about this group doesn't want to do this, or maybe won't do.
Dr. Perez, did you want to add anything to that?
Yes. Although Sharon, we want to talk about the discrimination of women in cardiovascular research for a long time, but let me talk about cancer a little bit. There continues to be a problem, although again, things are better. But the median age for the diagnosis of cancer in the United States is 66 years. So that means that half of the people with cancer get cancer when they're younger than 66, and the other half beyond 66. If we look at the median age of adults participating in cancer clinical trials, it's in the range of about 52. And the first figure comes from the National Cancer Institute, the 66 years. The 52 is based on my remembrance of most of the patients that we've enrolled in trials. So look at that discrepancy. The reality of cancer, median 66 years. The reality in clinical trials is about 50 to 52 years. This is a gap that we have to continue to close, because we need to, after we complete the clinical trials, to understand how the older or the younger populations, and this is not talking about race at all, it's about ageism that exists as a discriminatory factor in this world. We need to understand safety and efficacy for the older population, because they are the ones who are mostly affected by this disorder. And Sharon, I'll turn it over to you, if I may.
Well, I won't go on and on about heart disease in women, but I think important in this conversation is honestly the embarrassing maternal mortality in the U.S. And then you add that to the fact that a Black woman in the U.S. is at least 3 times as likely to die related to childbirth as a white woman. And white women in the U.S. are much more likely to die than many developed countries in the world. And the most common cause of that death is cardiovascular disease. And so when we think about, and I'll focus a little bit on women because that is a big focus of my practice, cardiovascular disease or not, but what we see in these communities, whether almost regardless, is that healthy women in communities, whether they are financially healthy or physically healthy or emotionally healthy, mean that their families and their communities are healthier. So focusing on women's health within whatever population that we are looking at can reap a greater ROI on our efforts than many other interventions. And I would argue that focusing on reproductive age women and pregnant women is one of the things that we can do the most. And we have many opportunities to impact the health of communities because pregnant women get care, right? They seek medical care most of the time, at least at the point of delivery. And that is an opportunity to help to assess the health of her newborn child, as well as the rest of the family in the community. And so I think a focus on maternal health, and particularly Black maternal health, is really something that will help all of the communities. It will help all of the individuals in the community and will help the health of our nation. And particularly because many of the causes of death in those individuals are related to undetected or untreated hypertension or other factors that could have been addressed. These are preventable deaths. So I won't go off on the heart disease in women because whenever I talk about what we don't know about heart disease in women, I follow that up. And if you think we don't know enough about heart failure in women or coronary artery disease in women, we know even less about heart disease in Black women or in Native American women or even in Asian women. So I think those are the things, by segmenting out our research, we will make progress. And I wanted to make one other point because we've mentioned bias during this conversation and what we might do. But one thing that we can do, and cardiology has done in a number of factors, is making checklists and guidelines and following them. So Dr. Dubny talked about how you never catch up. The people that are behind may never catch up. But I can tell you, if you say this particular drug saves lives if given after a heart attack, we should give it to everyone. And if you make sure, because it's a checkbox, that every patient who leaves your hospital gets that drug, you will see improvement in everything, because we're not even doing a perfect job in white men who have a heart attack, for instance. But the rising tide lifts all boats, and it lifts those people who had the biggest disparities the fastest and the most. And so that is another way to take the evidence that we know and apply it. So we actually, the default is the right thing to do for all individuals.
Dr. Dalbany, did you want to add anything to this?
Yeah, just to add a couple of points. And I think the question you asked was about the importance of what we call an inclusive research, right? So why is it important for African Americans, Latinos, Native Americans to participate in research? And I guess an extension to that question, why aren't they? And I think why aren't they question we've mostly answered earlier, because we haven't involved them many times in the planning of research and the execution of research. And that is important. What I will emphasize, though, is that I don't see any evidence that African Americans or Latinos are not interested in research. To the contrary, they are. Just like healthcare, we design our structures in such a way to almost exclude them. And I think the answer to a lot of this that Dr. Hayes said is to be intentional about why we're doing it and the results we seek. So if we want to have an inclusive research, we will have it. And I give an example of COVID. And National Minority Health Month this year by NIH is called Pounds Vaccine Ready. In Arizona, I decided to participate in the vaccine trial, and I got into it because at that point in time, and then the message has gotten around that the trial participants were not diverse. And so they stopped the trial to enrollment to other groups, except if you were in a minority group. So for once, because the trial was now tailored to people in my group, I was able to get in and participate. Why is it important to do it? The things that we participate in, we trust, right? So we trust in research because we were part of the research process. Like Dr. Hurley had said, sometimes clinical trials are the ways that cutting-edge treatments are made accessible to people, so that's important. Testing the efficacy of medications and prevention interventions in all populations allows to understand how it works across different settings. Whether it's through biology, the various circumstances in which we use healthcare, all of that gets embedded, and we miss that opportunity when we don't. And I will share with you, Tia, that's one thing that is in national consciousness currently is the issue of algorithm bias, right? These AI things that we use in driving medical care. And it is more pervasive than you think, right? And there's a lot of bias either built into the instruments or to the algorithms that are developed in populations that don't include enough diversity to the extent that when you now use it in everybody, including African American, Latinos, and other groups, it creates disadvantage, reinforces disadvantage, and could make it worse, make it less likely to get to healthcare soon enough. So it's a multifaceted. We have to increase the volume of data by getting access to people. We have to make sure the studies include enough people that when we generate these sorts of things to use to automate care as we want to do in the future with digital health technology, that it is actually helping people not systematically disadvantaged in the group. So those are some of the reasons why we must do it. And we can do it if we want to. It's a matter of intention and following through in our actions.
I just want to put in one other plug wearing my educator hat, in that it is imperative for all of us who educate the healthcare workforce of the future to also educate about biases that exist within healthcare. So very often, particularly in medical schools and residency, we are very focused on inundating our learners with facts and things that they need to know about taking care of the patient, but we may have less emphasis on really opening their eyes to what are the structural racism components that prevent healthcare from being equitably distributed amongst patients. And for example, this year, with all of the changes within the environment, we added in our medical school a week-long course on anti-racism. So it wasn't on really health equities and health disparities, although that was a part of it. It was titled anti-racism. And so, there have been studies that have shown that even when people of color have equal or higher educational levels, that they in some instances are still viewed by their healthcare providers of being less intelligent, less able to understand, and all of these things spill over into whether a provider is even going to offer a clinical research trial to someone if they feel that they're not going to understand this, or I don't want to have to take an extra effort, etc. So really, this gets to the core of how we educate the next generation of providers so that we don't propagate some of these structures that prevent us from achieving health equity in our communities.
Thank you. So we have just over 10 minutes left in the media briefing. So another reminder to journalists, if you have any questions, feel free to pop them in the chat so we can share them with our experts in the next 10 minutes or so. But the next area I wanted to touch in was, we know that a couple of the leading causes of death in minority communities are cancer and cardiovascular disease. And we have some of the top experts ever that can really speak to that. And so I'll direct this next question to Dr. Perez. What is your assessment for lack of health equity in oncology, but specifically breast cancer? Because we know breast cancer is an issue in the minority communities.
Yeah, in breast cancer, as far as I know, and Dr. Halyard, Michelle can obviously expand on this. It's again the combination of both biology and social determinants of health. Very clear in breast cancer. There are many different subtypes of breast cancer based on biological markers, but the main three types are really hormone receptor positive, HER2 positive, and triple negative. And we know there's a difference in the likelihood of these three subtypes to be diagnosed by race. So Black women have a slightly increased risk of developing triple negative breast cancer compared to the rates in whites or even in the Latinx population. But then if we look at the patients with triple negative breast cancer, just that disease, and there's a differential in outcome between the whites and the Black population. So we think that most of the difference in outcome, it's probably not as important in terms of biology. We don't know yet. We're still looking at this, but it's a matter of, are they getting access to going to the clinics where treatment is available? Are they seeking care early enough? Because the earlier we can diagnose a cancer, the better the outcome. So yeah, breast cancer is very specific. Some biology, but there's a lot of social determinants of health that have impacted the difference in survival rates after a diagnosis of breast cancer. Michelle, I don't know if you want to add to this.
Yeah. In addition to that, one can never underestimate the power influence of those around the patient. So from the lessons that we have learned with talking to, for the past 10 years, groups of women with breast cancer are, number one, we don't always talk about in our communities the fact that we are breast cancer or other cancer survivors, right? So when you look culturally, there's sometimes not discussions of successes of therapy. And so therefore people hear the negative sides of therapy. And so really designing interventions that help people really see the full value of treatment and demystifying, particularly if they do not have trust in their healthcare providers, providing opportunities to really demystify and debunk. I think, having access to the internet is great for information. Having access to the internet can be really detrimental if it's not high quality information. And so I think that, for some of our patients, particularly our breast cancer patients, there are a variety of reasons that they perhaps don't seek the care that's offered to them. A lot of it times it comes down to distrust of the provider, and or distrust of what the benefit versus risks are. So again, that theme of working with the community to appropriately educate and in a collaborative way so that credible information is relayed, I think will continue to enhance our ability to see disparities lessen over time.
And I'll join in on the cardiovascular disease because I would argue that although there are some biologic differences, the vast majority of the differences that we see in cardiovascular disease, both risk factors and outcomes, are socially determined and largely due to systemic racism. I think, when I learned about cardiology, I learned about the traditional risk factors, and they talked about, well, hypertension and African Americans have more hypertension and Native Americans have more diabetes. And that's the reason that they have higher risk of cardiovascular disease. But in fact, the prevalence of obesity, diabetes, or hypertension have roots in things that have nothing to do with biology or genetics. They have to do with redlining and living in neighborhoods that have poor access to safe exercise and physical activity and food safety. And I think I think where we need to pull people back, and this is why we had an anti-racism course here at Mayo for our learners, is to take a step back and realize when we start talking about food deserts or, what mother chose to live in an unhealthy environment? She did not. There are generations and generations of reasons that her people and her family were not allowed to buy or rent in places that were safer. And so if we take several generations back and consider how hypertension, which we know that the risk of hypertension is increased among those who have experienced racism. There are studies that have been able to show that actually the experience of racism increases cardiovascular disease risk and risk factors. So when we talk about cardiovascular disease, yes, there are some biological differences, and particularly across men and women. And there are a few things in certain Native American tribes where the risk of diabetes is just really much more, and it is genetically driven. But I think where we have to change our paradigm as we're looking at this is not just treating the risk factors for heart disease or treating the heart disease after it occurs, but looking at primordial prevention, which means preventing the risk factor from ever occurring. And that means addressing, whether we call it social determinants of health or we call it racism, that looking at how we can mitigate those effects. And this is a big job. I mean, if it was easy to do, we wouldn't be having this month. But I do think, particularly for cardiovascular disease, for which so many of the conditions are preventable by addressing risk factors, that's how we have to think about it.
Dr. Dalbany, were you going to add to that?
So we have 5 minutes left. There's a question on the chat. So I wondered if you wanted me to address that, and I'm happy to.
Absolutely. I'll read it. What are the ideas to respond to the next pandemic, the mental health pandemic, to reduce the gap in our communities?
It is a pandemic indeed, because with COVID, there's been an increase in demand for mental health services. I'm actually director of the National Center for Integrated Behavioral Health and Primary Care that is funded by HRSA, the Health Resources and Services Administration of Health and Human Services. And we've done studies that also show that this cuts across many, if not all, communities, including healthcare workers who are feeling their way to the pandemic, particularly perhaps in women who are having the dual role of being teachers at home, mothers, and also be working their regular work from home, my wife included, I'm sure. So this is a real issue. The biggest challenge that I'm seeing, I'm a family doc and I see patients in the clinic as well, is that because of the high needs, there's also really the resources are stretched. First of all, we didn't have enough behavioralists or psychiatrists to start with. Now we have a higher need for these services. So it's really more than one pandemic. We have a crisis on our hands. I would suggest a number of things. There's provisions now to provide access across state lines. Those are underutilized, and probably because there are not enough people to go around. Telehealth is really important, and telehealth provides access to people beyond the boundaries. But, we know that telehealth is not equally accessible by all people. And so we need to, again, use the same community engagement principles to help everybody make the most of telehealth. I want to highlight what Dr. Hilliard said earlier, that workforce is important. We need to train a diverse workforce, especially behavioral health and mental health workforce, to do that. One last thing that I want to throw in there for reporters to keep in mind. There's one model of care that we know works because there are not enough psychiatrists and primary care clinicians currently don't treat behavioral health conditions, mental health conditions well enough. There's a model called the integrated behavioral health in primary care, in which there's a team of people, including a psychiatrist for consultations, including licensed clinical social workers, behavioralists, who work with a primary care clinician to bring mental health care closer to where the patient receives their routine care. So those models are really terribly needed. They are not adopted universally. And reimbursement is not consistent. Creating parity is important. So that really should be an area of focus for it, because mental health affects everything, right? Your prevention, managing your hypertension, to your heart failure, to your lung condition, to your cancer, it appears everywhere, and it's paramount that we address this urgently. I will recommend integrated behavioral health care models in primary care. It's a team-based approach.
Thank you. So we are at the bottom of the hour. I have put the expert bios in the chat again if you want to access any of their information, as well as the Mayo Clinic News Bureau email address if there's any follow-up questions from our journalists or any other needs, and a link to the Mayo Clinic News Network for additional stories, additional resources, B-roll, photos, etc. I want to thank our experts so much for spending some time today with us and to talk through some of these very important issues and needs that are facing our communities. We have 1 minute left, so I'll open it up if there's any final thoughts from any of you that you want to share.
I'll take it. As I've matured in my life, I realized that it's good for us to have ideas, and it's also really good for us to see how we can really influence our environment for the betterment of the world. And then this environment starts, with what's around our arms and our brains, but then it can be leveraged for and coalescing the ideas of others. So I'm super excited about where we are, and I look forward to a better future.
All right. Well, thank you so much to everyone for joining us today. We appreciate it. Have a good one. Bye-bye.